The BVI Health Service Authority has just launched its Telestroke services. This service will not only save lives, it will also help to prevent the devastation of strokes and the quality of life of stroke victims. To discuss the Health Service Authority new Telestroke services is neurologist Dr. Ulysses Noble of HEMA Health of Puerto Rico and AHSA's, the Health Service Authority's Chief of Medical Staff, Dr. June Samuels. Dr. Noble, Dr. Samuels, welcome to Spotlight.
Thank you for inviting us.
Yes, good to have you on this really important development in the BVI. I want to talk to you first, Dr. Samuel, about what was the motivation for the need for a Telestroke service?
Well, as you know, Israel, I've been on this program before, and along with Miss Ivy George, and we've talked about the burden of chronic non-communicable disease in the BVI. And essentially what is happening is we're seeing all of the fallout from having such a high prevalence of chronic non-communicable diseases. So most people in the BVI would know we have a dialysis unit with 40-something plus, high 40s number of persons on dialysis, and a number of patients. We've been looking at our renal patients, a growing population of patients actually that now have renal impairment, which is secondary due to them having diabetes plus or minus hypertension. The other fallout that you see from this disease burden is the issue of strokes, and the number of persons who have stroke as a complication presenting for services is something that we've had a concern about now for quite a few years, because Dr. Noble has been working with us for somewhere around 5 years, he reminded me today. But we know that I think what has been of bigger concern to us more recently is that the number of persons with strokes who are presented at a younger age is growing, right? And our youngest stroke victim so far has been 22. And we see a number of persons within that 45 to 55, 35, 45 age group, that's the working persons who should be at the prime of their lives and working. And we know what the effects of having stroke and having disability from stroke from a financial, economical, and a psychological perspective can be. And so, collaboration with HEMA Health and the neurology services that they bring to us, we have been having ongoing discussions about using telemedicine to help us to be able to provide treatment for stroke, for acute stroke, here in the BVI. Within a timely manner, because that's really the main issue.
The key issue here.
The key issue, yes.
Now, I've talked about strokes on many occasions on Spotlight, but I've never asked what exactly is a stroke. And we see the manifestation of strokes, through the debilitating impact it has on its victims. But what actually happens to your body when you get a stroke, one, and what causes that thing to happen to your body? That's something I think perhaps we need to address.
Sure. By stroke, we mean any kind of partial damage to the brain that is caused by a disruption of the blood flow going up to the brain. So anything that alters the blood flow going up to the brain, to a part of the brain, will end up causing a damage to the brain. That's what we call stroke. Brain can be damaged by a variety of mechanisms, a gunshot wound, or stabbing, head trauma. So that is not a stroke. When we talk about stroke, we talk about any kind of lesion to the brain that is directly a consequence of the lack of blood flow to that part of the brain, or of a rupture or an artery inside the brain. So that is the mechanism of stroke. Of course, the most common one is the one that is caused by a blockage of an artery. That is almost like 90% of all the strokes. And the good thing about it is that we do have a treatment for that. We don't have any specific treatment for the other one, for the ones that bleed in the brain. But the ones that are caused by a blocked artery are the ones that, if they present on time, we can reverse. So that's why the need for trying to intervene immediately.
And I guess that's why it's a chronic disease in the sense that the blocked artery is caused by
Typically, it's a clot.
it's a clot, or
It's a clot.
is it also caused by nutritional deficiency or
Well, that's a good question. Now, what are the mechanisms that can lead to somebody to form a clot
yes,
and push that clot to the brain can be quite different when it comes to the brain compared to the heart. In the heart, the mechanism is the same, but it's pretty similar in terms that there is a disease of the artery in the heart. Usually, there is a combination of fat and calcium inside the arteries. At some point, that breaks inside the artery, forms a clot, and the artery ends up being blocked. In the brain, it's a lot more different. You can have clots from everywhere. You can have clots with the same mechanism, the heart, but also clots can come from the heart. For example, if you have some of the cardiac arrhythmias that are associated with clot formation, when the heart is pumping up the blood, it pumps the blood together with the clot, and the clot ends up in the brain. And also sometimes you have a different mechanism where the blood itself is not working normally and tends to form more clot than normal. So you have like an excess of clot formation that can affect the brain. So stroke, as you can see, is a lot more complex. The final mechanism is a clot in an artery that is blocking the blood flow.
Mm-hmm.
How that clot ends up in an artery can be coming from anywhere, and that's why we have to do a thorough investigation about what caused that to begin with.
But what role then does nutrition and exercise or lifestyle play in the prevention of stroke?
Critical. It is proven everywhere that it's sedentary kind of life. Somebody that is not doing anything, is not working, is not doing any kind of exercise, don't care about the diet. It is just eating a high carbohydrate or high fat diet. Of course, they have a lot more incidence of high blood pressure and diabetes and high cholesterol, and the combination of all of them end up causing a stroke and a heart attack, and so forth. And of course, smoking, because sometimes we tend to forget that, but smoking is a critical player in causing any kind of vascular disease, including stroke.
Okay. And now by having Dr. Samuel, thank you very much for that explanation.
No
and
problem.
I hadn't expected that much information. That's great information. Dr. Samuel, so we have the services here now, and we're going to talk about what those services are. But in terms of the benefits of the services, the economic benefits of the services for the people of the territory, what does that mean?
Well, we're talking about providing intervention earlier in the presentation of patients who may have stroke symptoms. Now, Dr. Noble will talk a little bit later about the people who will qualify for treatment, because not all stroke patients will qualify for this type of treatment, but it certainly allows us to be able to provide the treatment within the 4.5-hour window if once we meet it, by staff that has been trained to certification, the availability of medication. And so once you provide the treatment within the time frame and you're able to reverse the process, essentially, you can then have an individual who does not have a disability and who can return, basically have a good quality of life and return to their functioning. So we don't pay for rehab for this person if they're disabled with a stroke. They can maintain their work life, maintain looking after their family. You don't have the psychological issues associated with having a stroke. And so, the overall economics works in our favor once you're able to deliver the treatment.
And how does that work in terms of having to go overseas or go someplace else to get treatment? Is that something that's curtailed as well?
Right. One of the things about stroke treatment is that treatment earlier for thromboembolic strokes improves the prognosis in terms of the outcome, right? And in the event that, you know, there may be some person who still have to go overseas if there are complications or if they have another type of stroke, but certainly your numbers should of persons who are required to be transferred overseas should be less.
Okay. So we're going to save productivity, improve quality of life, reduce overseas travel. So the economic benefits are tremendous.
Absolutely. And when we've been looking at our numbers, you know, the number of persons who are presenting with stroke in that time of their life when it's their working adult life, you know, has been slowly climbing. Now, that is the section of the population that, you know, if we continue to have more and more numbers of persons, I mean, we can extrapolate on the effects on your social security systems, you know, your healthcare systems, you know, it can be a significant burden. So I think this is something definitely that, you know, we definitely would, it works in our favor.
Okay. Now, Dr. Noble, is there something that a person who is getting a stroke can identify immediately with the onset so that they can do something for themselves before treatment or before they have access to medical attention?
That's a great question. One of the, and this is just a comment, you know, more at a personal level. One of the things that we envy from the cardiology is that when somebody has a heart attack, they have so much pain, they feel they are going to die, that they go to the emergency room right away. On the contrary, patients with stroke usually don't have any pain. So it's for the most part, it's a painless disease, which ironically works against the patient because they don't feel any pain. They feel, oh, it's going to go away, I'm going to get better. But the typical symptoms are an acute paralysis of one side of the body. I'm talking about face, arm, and leg. It doesn't have to be the three of them. It can be only one alone.
So you just feel this tightness
Yeah, exactly.
in certain parts of your body.
Immediately you feel that one side of the body is not working normally. I mean, you lose power on that side. It can be that on that side, on a different side, you feel that it's numb. The sensation is not the same. You can lose vision also on one eye or both eyes. Another very common thing is trouble speaking. Somebody starts speaking funny, and not only can be funny because the way they pronounce, sometimes it makes no sense what they say. The pronunciation can be completely normal, but if you ask them, for example, the age, and they might say hello, they say, but I'm asking you how old are you? Hello. So they are speaking fine, but it makes no sense. So the last symptom that is pretty common is an acute onset headache, typically a bad headache associated with loss of consciousness, vomiting. That is typically a sign of an acute stroke. Most of those patients, they come to the emergency room right away. Why? Because they have pain.
Yes.
But the ones that we miss frequently are the ones that they wake up in the morning and, you know what, I'm having some trouble moving my right leg. And I got up from the bed and I fell down to the floor. But I don't have any pain, so I'm going to wait. And by the time they come to the hospital, there's nothing we can do. So one side of the body affected typically in terms of motor power, lack of sensation, visual loss, one eye or both, trouble speaking, and like I say, not only pronunciation, can be a normal pronunciation, but it makes no sense. And finally, that headache that is pretty bad, that it doesn't go away, that's the kind of patient that needs to go to the emergency room. But importantly, it happens suddenly. Nobody develops a stroke over a month or two. You are fine now, and in 5 minutes, you're completely paralyzed on one side. That's a sign of a stroke, and that's when you have to go to the emergency room right away. Immediately. Even if it turns out that it's not a stroke,
Yes.
you have to make that trip anyway, because you are not in a position to decide what it is. You have to let the physician check you out, because then you're going to have the greatest chance of improvement with an acute treatment.
Okay. And then now, once that's identified, and just say the person is at home and the ambulance has to go and pick that person up, are you able, how does the Telestroke service work? How does the telemedicine work in those instances?
Yeah, the telemedicine works in the hospital, so the patient needs to be brought to the emergency room.
Okay.
Okay, so via paramedics, ambulance, or private transportation, the patient has to be physically available in the emergency room.
Okay. Because I had this vision of
Correct.
Of the paramedic with his little iPad.
Exactly. Well, it is being done.
In the person's house.
Exactly. Well, no, what
administering
you are
the-
saying is being done in some other parts, of the United States, for example.
Mm-hmm.
They have because they have a good internet, you can do a quick consultation even in the ambulance with the phone. You can turn on Skype or any of the other application for video conferencing, even FaceTime, and you can communicate with the physician immediately. But typically, it doesn't happen that way. The patient has to be taken to the emergency room, and then is being evaluated there by the emergency room physician. Patients are finally diagnosed with an acute stroke. We get called and we connect via internet. I am on the other side of the computer, and the patient is right here, and I can see what the patient looks like, what the vital signs are, blood work, all the information of the family. Because I'm even speaking with the family. I can hear everything. People sometimes don't know that, and they start chatting, and I can hear absolutely everything. So, and it's a good thing sometimes, because I have picked up some physicians that they are ordering a medication that is completely contraindicated in that patient, and I just overheard that from the internet. So I was able to stop them from giving that medication just because I heard that. I have a complete view of what's going on. Even though you don't see me in person, I do see everything that is happening.
So the person has to come to the hospital. Okay. So how much training do our paramedics and the ambulatory care require to deal with the stroke victim en route to the hospital, and also once they're in hospital and connect up to the remote neurologist? How much training is needed?
Well, over the last, I would say about 6 months to maybe a year, HemoHealth Stroke Program is an accredited program, and therefore we have been required to get our staff certified, and there is training that the team has come across and they've done with the different groups. And so the EMTs, paramedics, they're concluding their set of training today, and really it's about identifying the symptoms and calling back and letting us know this is a possible stroke, because that determines what happens subsequently once the patient gets to the hospital. So
once the ambulance or the paramedic gets to the site to pick up the patient, and
there's a brief screen assessment that they do, which,
and then you have to prepare to receive.
Right, which is done starting there and en route. Okay, and once the suspicion is there that we need to consider stroke, that call is made back to ER, because then the whole system then needs to roll out once the patient hits the door.
Okay, so you want everything to be ready. You want Dr. Noble to be on the line. You want the teleconferences to be hooked up and ready.
Right. So there's a whole stroke code that the staff has been trained up into, and once we hear possible stroke, the code, the whole process starts to flow.
And you have a 4-hour window to get everything ready and done in order to help to prevent a more catastrophic event.
Yes.
Yeah. Okay. Now, Dr. Noble, to take us through the process, once a patient gets in to the hospital, what happens? How does the Telestroke service work?
Once the patient gets into the emergency room, the patient gets immediately evaluated by the emergency room physician and the nursing personnel. And one of the first things they need to do right away is to do a head CT. We need to see what the brain looks like. Why is that? Because let's say the patient had a bleed in the head instead of a blocked artery, then the treatment is completely different. So for us, doing a head CT is a number one priority. So when the patient gets into the emergency room, on top of being sure that all the vital signs are stable and the patient is not gonna die immediately once the patient is stabilized, gotta go stat really in a rush for a head CT, and they need to be able to upload those pictures to the internet so where we can see them from our side. Once we see the CT, we don't see anything major wrong in the CT, then we have to start taking the history about the onset time, medical history, medications, and so forth. So at the end, after we got all that information, which might be like a long time, but in reality it's pretty short, we do a full examination with the physician locally and us on the other side. So I typically advise not to do a full exam until I am there because they're going to be wasting time because I'm going to have to see that exam anyway. So I rather make them wait a little bit and do an exam together where I can watch exactly what the patient looks like and get information from the family and all the tools that I need to be able to advise on the treatment. Important is to know, and again for the people that I don't want everybody to go to the emergency room and think that everybody's going to get telemedicine. No, right. Telemedicine is only for the set of patients that they had an onset of symptoms in the last 4 hours or less. Mm-hmm. So people that comes with a longer time will not qualify for telemedicine. That doesn't mean we're not going to do anything for them. It just means that it doesn't qualify for telemedicine. So
well, at that time, the window of opportunity would have passed, and it would have been too late to prevent whatever catastrophic event would have occurred.
Exactly. So we won't do telemedicine with them. Of course, we're going to be able to help them in different ways, whether the patient needs to be transferred or we need to give them some advice to the treating physicians. I mean, we're not going to leave that patient like, we're not going to do telemedicine. We don't care about the patient. We do. But it's not going to qualify for telemedicine. And on top of that, even the ones that qualify for telemedicine, not all of them are candidates for an acute treatment. Sometimes patients qualify for telemedicine, but we do find a major contraindication for the drug that we use, and he or she won't receive that medication. So I always want to be clear with that because sometimes families comes with an unrealistic expectation that we're going to treat everybody. And it's not that we don't want to do it. We have a protocol, and you have to follow the protocol because if you don't follow the protocol, you make the patient pay a heavy price, and the heavy price is that you can kill the patient with the treatment. So you have to be absolutely sure that there are no major contraindications, the patient qualifies, and then we go with the treatment. So, but it doesn't happen with everybody, even the ones that come right away.
Okay. So after you've done the brain scan, and you find out that you can't treat you need to treat the patient immediately. Then you give instructions to administer the medication on the spot.
Correct.
Okay. And by doing so, you then reduce or increase the person's chances of having more, retaining more functionality.
Absolutely. When you look at the numbers, for every 100 patients that we treat with this medication, approximately 30% of them, they're going to return back to almost a normal life. So it's not the best or the greatest medication for a stroke, but it's the only one that is approved. Compared to doing nothing, where nobody got better. So the numbers are those. For every 100 patients that we treat with this medication, 32 of them, 33 of them, they're going to get a good outcome. And most of them, they're not going to get any major improvement. And there are only a few ones, approximately 2 to 3 patients, that can get hurt because of the treatment. So that's why we have to be very selective in who we choose. But those are the numbers and the ones that got better, trust me, it is quite impressive when you see somebody that is completely devastated in the emergency room, and 3 days later, they walk out of the hospital like nothing happened.
Okay. Well, I want to go over and give a visual, through a description of what it means to receive this treatment in terms of functionality, in terms of maintaining quality of life, and what it means not to receive the treatment.
Correct.
Yes. So can you go over, say a person that comes in with a stroke, and this treatment is not available, this service is not available, what what is likely to happen to that person physically in terms of his quality of life and his motor skills
If they do receive the treatment.
if he does not receive the
It
treatment?
does not receive the treatment. For the most part, patients that come with an acute stroke, with a blocked artery, that don't receive any treatment, they're not going to get, in general, any significant improvement. However, I mean, I have to be honest, some patients, especially the young ones, they recover some. It's very unlikely to be a fixed deficit forever. They do recover some. The problem is that some recovery is not enough to make them be in a normal functioning human person again in society.
And you're talking about an abnormal functioning person. An abnormal person in society would be someone that can't use what?
He can walk, can speak, can go to the bathroom, can eat alone, can work, can be a functioning person for the society. So that's what we're trying to do. We're trying to put that person again back in a society and not being a burden for the family, the society, and even for the government.
So you're talking without this treatment, you could almost end up in a vegetative state.
That's right. That's right. And we've seen that. And what bothers me the most is that we are seeing younger and younger patients getting hit with this disease, because what happens is that stroke can kill you, but for the most part, it won't kill you. It will leave you permanently disabled, which is more cruel in a way.
Yes,
You know,
I would
because,
think so.
well, yeah, sometimes people don't see it that way. And I say, after I've seen what I've seen so many times, I'd rather be dead than the way that I've seen some of the patients. And stroke, unfortunately, it has a high mortality, don't get me wrong. You know, it's like the third leading cause of death. But the ones that don't die, those patients that don't die, for the most part, they are permanently disabled forever.
And now, and a person now who have gotten through to the emergency room within that window of opportunity and has received the telemedicine, that person is restored to what level of functionality?
Yeah, well, it's not guaranteed that will happen, but they have a much higher chance of getting back to a normal functioning again compared to somebody who didn't receive any treatment. Like I said before, approximately 30% of those patients that do receive treatment, they're going to go back to almost a normal or a fully normal health following the treatment.
Okay, that's great. Dr. Samuel, certainly this is a major accomplishment in health for the people of the territory. I don't know if there's anything else you want to add.
It definitely is, and it's an accomplishment that's happening thanks to Dr. Noble and his team at HEMA after a few months of a lot of work, because it's a lot of training. The staff, as I said, they had to become certified, which meant going to classes, going online, doing the exams. The nurses, all of our emergency room staff are now certified in assessment of stroke, and our internal medicine staff and the critical care unit nurses are also certified in assessment and follow-up, because once the patient receives the treatment, there's intensive care that has to happen over the next 48 hours, and they've worked through all of those processes. It is, I think, given what Dr. Noble has mentioned from his perspective, seeing patients having to live with stroke, and I think it is even more painful to see patients who are 35, 45, having to live with stroke and what that means in terms of their functioning on a day-to-day basis. And as I always say, we have our greatest resource here is our human resource, and we have to do whatever we can to protect our human resource. So I think this is a great service for the people of the BVI.
Yeah. Now, Dr. Noble, this is one aspect of, and I don't know if you can speak about generally, but this is one aspect of the relationship, the partnership between the Health Service Authority, the BVI Health Service Authority, and HEMA Health Puerto Rico. We have some other relationships as well that HEMA Health generally brings to the Health Service Authority. Can you speak a little bit about that? Is that something that's Or you just a Telestroke person?
No, I know. I know. I know that I have some of my colleagues coming to BVI to do different clinics. I know one of them, for example, that runs a dialysis clinic here in BVI. There are other colleagues that come for pulmonary problems. We have even general surgeons also coming to BVI. So I think cardiologists also. So there's a group of different specialists that are coming to BVI. And I think it is very important. Remember that the best way to prevent a stroke, I mean, when you reach a telemedicine point, that is the last event after a lot of things were happening and you didn't know. So the best way to prevent to seeing me in telemedicine is to take care of your blood pressure and diabetes and cholesterol and avoid smoking and a healthy diet. So prevention is critical, and you don't need us for telling you that or doing that. The physicians, that are working here in BVI, they know that quite well. Of course, it is also up to the patients to follow the advice of the physician. Sometimes the patients don't do what the physician tell them to do. I mean, you cannot intervene in that level, but the best way to prevent a stroke is to control all those things that are quite common in our population and also here in BVI. Now, let's say you do everything and still end up having a stroke. But that's when we come to the rescue we can. But for the most part, it is a highly preventable disease. People don't know that. People take it as an accident. It's not an accident in the great majority of the patients. It is something that you can foresee, from a while, that patient is going to end up with a stroke because they're not taking the medication, they do what they want, they eat what they want at any time of the day, they don't control diabetes, they don't do anything for their
Don't
own
exercise.
health. Exactly. So, I mean, you're looking for trouble if you do that, and you're going to get it. Sooner or later, you are going to get it, and for the most part, with no warnings. So stroke, for the most part, only 10% of the patients get a warning, the so-called TIA, which is like a mini stroke where the patient recovers immediately. That's the one that needs to go to the emergency room right away. But those are only a small fraction of all the patients. For the most part, you have no warning and hit you suddenly.
Dr. Noble, thank you very much for coming to spotlight you and Dr. Samuels. We appreciate all the information that you've given us, and of course we want to take the advice that an ounce of prevention is worth a pound of cure.
Right.
Yes.
Thank you
Thank
for
you for
inviting
having
us.
us.
Certainly welcome. I've been having a discussion with Dr. Samuel, Chief of Medical Staff at the Health Service Authority, as well as Dr. Ulysses Noble of HEMA Health Puerto Rico. We've been talking about telemedicine and telestroke services that has been launched at the BVI Health Service Authority and the Peebles Hospital, of course. Spotlight is seen Tuesdays at 8 p.m. here on JTV Channel 55 and rebroadcast every Sunday at 2 p.m. I want to thank you for watching, thank you for your words of encouragement, and thank you for your criticism. Like our Spotlight Facebook page and watch the discussion you didn't miss. Find out about the upcoming shows and all the guests and new topics that's going to be here on Spotlight. I'm Medjuenka, reminding you that when the spotlight is on, you see the facts.
Spotlight is brought to you by Tortola Concrete Limited and H. Lavity Stout Community College.